Now, I'd like to welcome everybody to our webinar today. My name is Jane Clare and I'm the Education Resource Manager for ISQua. Our webinar today is by Glenn Robert and it is Using Experience-based Co-design to improve patient experience and staff well-being, lessons learned and future directions. So firstly, I'd just like to introduce Glenn and give you a short introduction. And his research draws on the fields of organisational studies and organisational sociology and focuses on quality and service improvement in healthcare and new perspectives on large-scale change. He's co-authored or edited 5 books, including one based on major systematic review exploring the diffusion of innovations in healthcare delivery and organisation. This won the 2006 Baxter Award for Most Outstanding Contribution to Healthcare Management in Europe. So we're very excited, Glenn, to have you today to present our webinar. And just before you start, I'd like to remind participants that there will be 3 questions posted after the webinar in our fellowship forum that you must answer in order to gain credit points, and also that there are some videos in this presentation, so you may want to turn up your speakers in order to catch all of the sound. Okay, Glenn, are you there?
Yes, I am. Hi.
Super. I'm just going to make you presenter now and then you will be able to take over.
Okay, great. Well, thank you, Jane.
Thanks, Glenn.
Thanks, Jane, and welcome everyone. Glancing down the list of those registered for the webinar, there I think are at least 13 countries represented. So I won't offer any time-specific greetings, but whatever part of your day this is, I hope you'll find the next hour or so informative, and I look forward to your comments and questions. I'm going to talk about using experience-based co-design to improve patient experience and staff well-being, and reflect on our experiences of over 80 implementations of this particular quality improvement intervention, as well as present some recent adaptations to the approach. Now, as some of you may be aware, experience-based co-design is largely a narrative-based approach to quality improvement, and so I thought I would adopt a similar approach in explaining how it has developed over the last 9 to 10 years. So this presentation will be something of a chronology, beginning with a brief description of the origins of EBCD, its initial development through a pilot project in a head and neck cancer service in 2005-06, then its more widespread adoption in the period 2007 to 10, and then bringing it up to date. I'm going to highlight 3 recent adaptations to the approach before concluding with some reflections and suggestions for future directions. So in terms of where experience-based co-design originated, if you cast your mind back to sort of 2005, 2006 in terms of where quality improvement in healthcare was, here in England at least, and I know in many other countries, quality is conceptualized as having 3 main components, that is clinical effectiveness, patient safety, and patient experience. But certainly back in 2005, patient experience was seen as the weakest link of that quality tripod, if you like, the poorer cousin to clinical effectiveness and patient safety, where most of the investment and attention was paid in terms of quality improvement work. But since 2005, an evidence base has begun to emerge, at least, suggesting that organizations that are more patient-centered have better clinical outcomes and are safer. That, more specifically, for example, improved doctor-patient communication leads to greater compliance in taking medication and can enable greater self-management for people with long-term chronic conditions. And more generally, that individuals' anxiety and fear can, in fact, delay healing. If you now fast forward to sort of 2012 to 2013, leaping forward 8 or 9 years, then we see many more papers looking at this link between patient experience, clinical safety and effectiveness, and the relationship between those 3 components of quality. So recently in BMJ Open, paper by Doyle et al., systematic review that suggested that there was consistent positive associations between patient experience, patient safety, and clinical effectiveness for a wide range of disease areas, settings, outcome measures, and study designs. And in the New England Journal of Medicine, no less, perspective papers looking at, again, this link between patient experience and health outcomes. In 2012, Karen Luxford's editorial in the International Journal for Quality in Healthcare posing the question, what does the patient know about quality? And the same year, 2012, an empirical study looking at a problem that bedevils patient-centered quality improvement, this gap between the rhetoric and the reality of having quality improvement interventions that are truly patient-centered, a survey by Rosenblum et al., looking at the gap between hospital management and frontline clinician views about how patient-centered quality improvement is actually implemented. So it seems we've come quite a long way in the last 8 or 9 years in terms of thinking about this relationship between these three components of quality. But if I rewind again back to 2005, and really the origins of experience-based co-design were when Helen Bevan, who many of you may well know, was at the NHS Institute of Innovation, a leading light in quality improvement work here in England and indeed around the world. And Helen asked my colleague, Professor Paul Bate, and I to spend a little bit of time just having going on a bit of a scouting expedition and seeing whether there were bodies of literature outside the mainstream quality improvement work of the time, much of it led by the Institute for Healthcare Improvement, of course, Lean, Six Sigma, those types of bodies of work. Were there other bodies of literature, ways of thinking about quality improvement that we could bring to bear on what was going on in England? And so Paul and I went away and did that and came up with two particular bodies of literature which we thought were promising. The first was around social movement theory and how social movements develop and have impact on society. And we, with Helen, developed a stream of work around that, which Helen has now taken forward in terms of large-scale change across healthcare systems. I'm not going to say any more about that today. But the second body of work that we picked up on was design theory. And we were particularly attracted to this because it draws its inspiration from a subfield of the design sciences, and it really answers the question of how do people like architects and software engineers think about designing a new building or a new product or indeed a new process. And it has a couple of key features. Firstly, direct user and provider participation in a face-to-face collaborative venture to co-design services. And then secondly, a focus on designing experiences as opposed to systems or processes. And I think in part, Paul and I were attracted to design theory in the way in which designers think about new services and products, precisely because of this move away from a focus just on systems or processes, which is where most of the quality improvement work in healthcare at the time was focused, and paying attention much more to experiences and relational interaction. And if you're going to study experiences and design them into healthcare systems and processes, that requires ethnographic methods such as narrative-based approaches and in-depth observation. One of the core concepts that we picked up on from the design literature was the notion that any great building, any great design, any great service has three core components, and that is performance, engineering, and the aesthetics of experience. And so designers, as far as the performance component is concerned, ask the question, is it efficient? Something that we in healthcare quality improvement try to answer through approaches such as Lean, for example. The second component, engineering, designers will ask, is it safe and reliable? And obviously there's lots of patient safety interventions that are used widely in healthcare. But the third component, the aesthetics of experience, designers ask, what does it feel like? And by that they mean both the physical and the human environment. And this was where Paul and I felt that there was a gap in contemporary quality improvement interventions in healthcare. And it was really there that we saw experience-based co-design having a role to play. This cartoon, I think, illustrates the point that will resonate with many of you, that in the relentless drive for efficiency and performance improvements in healthcare, we sometimes forget that there are trade-offs with issues such as patient safety and patient experience. And just by cutting unnecessary visits by over 23%, while that may be increase efficiency, there may be some trade-offs to pay in terms of safety and experience and overall quality. So to cut a long story short, what we found from a design perspective, if we were going to bring some of the concepts from design theory into healthcare quality improvement, then healthcare quality improvement must obviously fulfill the core task and be safe, the performance and functionality components. But we must also begin to think about how healthcare services appeal at the emotional and sensory level, the aesthetic point. And in doing so, patients and carers need to be active rather than passive, using their specialist form of knowledge that only they possess, namely experience. And around 2005, Paul and I wrote a paper sort of summarizing some of the lessons that we thought we picked up from the design theory literature. It was published in BMJ Quality and Safety in 2006. So that was kind of the origins of the idea. But then we set to actually developing an intervention based on some of the insights that we felt we'd gathered from looking at the design theory literature and the way in which designers think about new products and services. So in 2005-06, we actually set to designing an intervention based on what we'd learned. So we're funding again from the NHS Institute for Innovation and Improvement, support from Helen Bevan and others. We piloted an approach at Luton and Dunstable Hospital in the south of England. We called the project Your Experience Matters, and we piloted it in a head and neck cancer outpatient service. And there was a small team of us, myself and Paul at the top of the picture, Kate Jones from the Trust, a designer, Deborah Trebecco, Lynn Marr, who was working at the NHS Institute at the time, now based in New Zealand, Elaine Hyde, who is the Quality Improvement Facilitator at Luton and Dunstable, and a filmmaker, Ivo Gormley. So the small team of us set about trialling this new approach, which essentially was a participatory action research approach that combined a user-centered orientation, that's the experience-based bit of EBCD, and a collaborative change process, that's the co-design element. And what we were seeking to do was to try and meet the challenge set out in this quote from Demos in 2008. And that is, where user and provider can work together to optimize the content, form, and delivery of services. At its most highly participative extreme, this process is referred to as co-design and entails service development driven by the equally respected voices of users, providers, and professionals. And I'll come back later in this webinar to this notion of its most highly participative extreme, because I think what we've seen over time is quite a lot of variability in terms of the co-design phase of experience-based co-design and the extent to which patients and carers are truly seen as partners in that co-design phase, which I think is crucially important to the impact of the approach. So the participatory action research cycle that we developed and called experience-based co-design has 6 stages, as shown here. I'm not going to go into detail about each of these today. There is, and I'll point you to it later in this webinar, an excellent, very detailed online experience-based co-design toolkit, which is free to access, free to use. And if you want to find out more about the specifics of each phase, then please do go there. As I say, I'll give you the web address later. But essentially, there are 6 phases: setting up phase, usual kind of project governance, advisory boards, etc. And then beginning to engage staff and gathering their experiences before moving on to engaging patients, gathering their experiences. Then stage 4, the first time that the patients and staff come together in the first co-design meeting to share their experiences and to identify their shared improvement priorities. And then the important phase of smaller co-design teams forming around those improvement priorities, actually testing and implementing changes before everyone comes back together again at a final celebration event. As I say, I'm not going to go into much detail about each of those 6 phases. I'm just going to give you a flavour of them from the pilot study that we did in the head and neck cancer clinic. So having set up the project, the next phase is to engage with and gather staff experiences. Through non-participant observation and semi-structured interviews, we seek to learn about the staff experiences of the service and what they would identify as the priorities for improvement, both for themselves and for the patients that they care for. So a picture of Paul spending time with the maxillofacial surgeon at the head and neck cancer service where we were piloting this approach. And a picture of me with more hair and slightly slimmer, doing some semi-structured interviews with staff, Paul taking field notes at a staff meeting. And then we analyze the data in the usual way from those interviews and observation and feed it back to the staff through the, in this case, the clinical director of the head and neck cancer service, John Pickles. And that's a fairly sort of standard feedback event, reflecting back what's come out of the interviews and the observations, and asking staff to come together to identify what they feel are the priorities for improving the service. Now, almost in parallel with that process of staff engagement and gathering staff experiences and identifying what their improvement priorities are, we also begin the work of gathering patient experiences. And I just wanted to, slight tangent, but I think it's an important point. This specialist form of knowledge that patients hold, experience, how do we access this? Now, one way, obviously, that people try to do this is through patient surveys. So here you see a response to a patient satisfaction survey. Overall, did you feel you were treated with respect and dignity while you were in hospital? Response, yes, always. Overall, how do you rate the care you received? Excellent. Another way of accessing patient experiences, this specialist form of knowledge, is to use a narrative-based approach. So here's an extract from a patient narrative. The other thing I didn't raise, and I should have done because it does annoy me intensely, the time you have to wait for a bedpan. Elderly people can't wait. If we want a bedpan, it's because we need it now. I just said to one of them, I need a bedpan, please. And it was so long bringing it out, it was too late. It's a very embarrassing subject. Although they don't make anything of it, they just say, oh, well, it can't be helped if you're not well. And I thought, well, if only you bought the bedpan, you wouldn't have to strip the bed, and I wouldn't be so embarrassed. The important point about this slide is that these two responses are from the same patient talking about the same episode of care. So this is a female patient on an elderly care ward in another hospital in the south of England. The important point to draw from this is that the local quality improvement priorities that you would draw from these two ways of accessing patient experience are very, very different. So from the patient survey, the respondent talks about always being treated with respect and dignity and rating the care she received as excellent. Whereas just from this one extract, very short extract from a much longer narrative interview, there are already several potential quality improvement priorities arising. So what we attempted to do with experience-based co-design was to take a strongly narrative-based approach. So we were asking patients and carers to tell their story, and we wanted to film them so that we could then bring those films back to a larger group to get a shared reflection on what it was like to be a patient carer going through a particular service. So we would typically film about 16 to 18 patients or carers talking about their experiences of the same service. Then we would bring those patients together to watch a 30-minute edited film compiled by us as a mechanism, as a trigger for getting them to reflect on their experiences as a group. Then we take them through a series of facilitated exercises, again getting them to reflect on their experiences, firstly individually, but then as sharing those experiences as a group. All of this leading to a shared set of improvement priorities that they would like to take to the co-design meeting when they met with the staff for the first time. So you see a picture here of one of the exercises where these head and neck cancer patients have been mapping out the really important moments of their journey through the head and neck cancer pathway. including adding their emotions, the emotions that they felt at various points. You can see some of the examples here. And what we're looking to do at this patient feedback meeting, where they come together to watch the compiled film and also to go through these exercises, is what we call touch points, which comes very much from the design science literature. So these are the critical points, the big moments, good or bad, the moments of truth, the emotional hotspots that have really shaped these patients' and carers' experiences of this head and neck cancer service. And just to give you some examples of what we mean by touch points, so, and these emerged from the particular pilot project that I'm describing, one would be the breaking the bad news moment, when you're given the diagnosis of cancer, clearly a key touch point. Another would be what would call the mirror moment. So many of these patients would undergo quite traumatic head and neck surgery, and it was intended that the first time they saw themselves after that surgery, post-surgery, they would always be accompanied. But what we found from the narratives and from the group discussions was that many of the patients saw themselves for the first time in the mirror in the bathroom, on the ward, or in their room, and they were alone when they did so. Another touch point is the fitting of the radiotherapy mask. Many of these patients would go on to have extensive courses of radiotherapy, and that fitting of the mask was clearly a touch point for many of them. And the final example would be the PEG feeding tube. So post radiotherapy, the patients would be fitted with a PEG feeding tube. This is an interesting touch point in particular because it's one that none of the staff in their semi-structured interviews and their discussions ever identified as potentially being a priority, a touch point for the patients. But when we collected the patient narratives and stories, they spoke about the PEG feeding tube as being the moment when the cancer was made visible and as being the final straw almost. Key touch point for the patients, and one that came as a surprise to the staff, and as you'll see later on, one that became one of the improvement priorities that they together then worked on to make better. But I just at this point wanted to play a short clip. This is a compilation of two of the head and neck cancer patients talking about a particular touch point, which I think this is a really nice example of what we mean by a touch point. So these two patients are both talking about their attendance at what they thought was a radiotherapy planning meeting. So this is a short clip. It lasts about 3 or 4 minutes, I think. But I play it because I think it's one of the best examples of what we mean by a touch point.
So when I was called in, there was a nurse who I didn't see immediately, but the person I saw, somebody called Adam. I'm sure he won't mind mentioning his name. Having said hello, and his name was Adam, said, right, stripped the waist. And I was absolutely dumbfounded because I simply didn't expect that this was anything to do with an examination or whatever. As far as Mount Vernon is concerned, I didn't get much information. I met a friend who warned me. Little issues. She said they were asked you to strip to the waist. So I was prepared for that. But there was another gentleman in the room, you know, a professional man. I'm quite used to that, but they do say, they don't say would you get under it, they say strip to the waist. And I found that a bit, and I looked across to Adam, and he said, well, it's all right, we're quite used to it. And I said, yes, I'm sure you are, but I'm not. So they give you a piece of paper to come in, somebody strips the slides. And I can remember the nurse trying to, when I was on the couch, trying to pass me some very stiff paper to put over the top of me. Of course, it wouldn't stay on anyway. And looking back, it was probably quite amusing, but at the time it wasn't really. And I know that somebody else actually said something to Adam, and he said, well, I'm so used to it. But of course he is, but we aren't. So he probably has the message, and later on I did meet him again several times, and he couldn't meet a nicer person.
So just to think a really nice example of of how a moment in a patient's journey can be a real touch point for those patients. It's something that's almost neglected or not thought about by staff. This example of going to a radiotherapy planning meeting and asking to be immediately stripped to the waist and being given the brown piece of paper, which had clearly stuck very vividly in these two patients' minds. So having engaged with staff, gathered their experiences, fed back to them, done similarly with the patients using the film as a trigger, we're then on to stage 4, the co-design meeting, where the patients and staff come together for the first time. Together they watch the compiled film with the patient interviews. The staff hear what the patients have prioritized as their improvement priorities for the service. In turn, the patients hear what the staff have identified as priorities for improvement. Then again, through a facilitated exercise, the patients and staff come together to agree on their shared priorities, and the co-design groups are then formed around those to make these improvements. So an example from this first pilot in a head and neck cancer service was around the first visit to the outpatient clinic. Patients describing that as the gateway to what follows and how frightening it was, and making some suggestions as to how their experience of visiting that outpatient clinic could be improved. Again, to cut a long story short, over a period of about 3 or 4 months, those 6 co-design teams were formed around shared improvement priorities. About 70 different actions were logged and 43 quality improvements implemented. These included issues around the weighing scales that were visible in the outpatient clinic, staff training needs analysis, the issue of the PEG feeding tubes that I've already alluded to, and issues around the physical environment in the outpatient clinic. And if you want to know more detail around that pilot work, then Paul and I wrote a paper for the Journal of Applied Behavioral Science, where we used the pilot at Luton and Dunstable as a case study, and also the book that we wrote, which forms the basis of the experience-based co-design approach. So we'd gone to the design science literature. We picked up what we thought were some interesting insights and lessons for quality improvement work in healthcare, particularly around that third component of quality, patient experience. I now want to go on and just briefly describe how the approach came to be more widely adopted in the period 2007 to 2010. So Paul and I were engaged to do some work in New South Wales for New South Wales Health around a large-scale clinical services redesign program that was running at the time. And while we were there, we met someone called Jane Gray, who had a lead for improving patient experience at New South Wales Health at the time. And we spoke to her about our experiences of this pilot work in England. And Jane was very interested in the approach and managed to get some funding to introduce it in New South Wales, but on a much larger scale than we've been able to in our pilot work. And so Jane led a program with others of implementing experience-based co-design in 7 emergency departments in New South Wales. The project was split into 2 stages. In the first stage, 3 emergency departments took the approach and implemented it. And in stage 2, 4 further emergency departments partnered with another department in their hospital, because issues around transitions from emergency departments to other departments and wards was obviously key. So in total, it was implemented in 7 hospitals, and this was the first opportunity that Paul and I could have to see how implementation varied when different hospitals, in this case emergency departments, adopted the approach. So you can see there's quite a range in the terms of the numbers of the patient interviews, numbers of staff interviews, and particularly the hours of non-participant observation that were carried out in these 7 hospitals. So in at least one of the hospitals, no observation was carried out at all, and I'll come back to this later in this webinar, because I think this is actually a much underused resource in healthcare quality improvement still, and I think it's an important part of the experience-based co-design approach. Just to illustrate that, these are a couple of nice pictures from one of the emergency departments. This is from Bankstown Hospital in Sydney, where just to illustrate the power of non-participant observation, a wonderful image of what the patient experience of checking in to this emergency department was like. But equally important a picture of what the experience of the reception staff in this emergency department was like. And I think there's a wonderfully illustrative examples of the real importance of non-participant observation in this approach. So across these 7 hospitals in New South Wales, these 7 emergency departments, several common improvement priorities emerged around patient and carer comfort and privacy, physical space for staff and patients, communication and information flow, and a wide range of solutions, quality improvements were made in response to those. For example, a designated nurse to manage the waiting room and communicate with patients, informed waiting training for all staff, and the emergency department being redesigned to ensure both the triage nurse and clerical staff have clear views of the waiting area. Now, importantly, Jane also commissioned an independent evaluation of the implementation of EBCD in these 7 hospitals. It's carried out by Professor Riccadima and his team at University of Technology, Sydney. And I just wanted to share with you a couple of the overall findings from their evaluation. So what they found was that the primary strength of EBCD over and above other service development methodologies was its ability to bring about improvements in both the operational efficiency and the interpersonal dynamics of care at the same time. And this seemed to us to be an important finding, going back to our original premise that if we want to develop high-quality healthcare services, we need to pay attention to those issues of performance, functionality, and aesthetics. And it seemed as if, in this implementation at least, EBCD was getting both of those issues of efficiency, but also around aesthetics, the interpersonal dynamics, the human environment in these emergency departments. And the evaluation team also went on to note that EBCD teaches project staff new skills. It enables frontline staff to appreciate better the impact of healthcare practices and environments on patients and carers, engaging consumers in deliberative processes that were qualitatively different from conventional consultation and feedback. So it seemed that we were obviously very interested in the evaluation of the Australian projects in New South Wales, not least because of the variation in terms of how the different teams adopted the approach. Back in London, we then got more closely involved in a large-scale project using EBCD, where we tried to move to a model of knowledge and skills transfer. So unlike in the original pilot work, where it was Paul and I doing the interviews and leading the facilitation with the support of the design team, here we deliberately tried to transfer the knowledge and skills to 2 in-house quality improvement specialists in the healthcare organizations where they were working, and we mentored them through the process. The fieldwork involved 36 filmed narrative patient interviews, lots of ethnographic observation, staff interviews, and then the facilitated EBCD process over a 12-month period. And we tried to put a much more rigorous and robust evaluation framework around this particular implementation. So we mapped the quality improvements, and 2 years after the end of the project, we went back into these services to study whether those improvements had indeed been sustained. In the case of this project, 7 co-design groups were formed, 56 quality improvements were implemented, and as I say, about 2 years after the initial implementation, we went back in to see whether those improvements had been sustained, and we found that about 2/3 of them had. We also tried to tease out a little more what type of improvements were being made in terms of the scale of change that was required. So most of them were what we termed quick fix solutions, 28 of those, with most of them having been sustained 2 years post-implementation. Then there were some process redesign solutions within a service. Then there were some cross-service or interdisciplinary solutions, more complex. But also there were some organizational level solutions. But one of the other things we found, going back 2 years into these services, 2 years post-implementation into these services, when we interviewed the staff who had taken part in the initial projects, was the crucial role of the facilitators in determining staff experiences of the experience-based co-design approach. So our model of knowledge and skills transfer which I'm sure is the right one, about developing capacity and capability within organizations to lead these types of approaches, did throw up some interesting findings about what were the skill sets needed by these in-house facilitators, what were the most appropriate skill sets for this type of approach. And one of those facilitators, Catherine Dale, based at Guy's and St Thomas's Hospital in London, took the lead in developing a toolkit for other practitioners, quality improvement practitioners, clinicians who were interested in experience-based co-design. And in partnership with the King's Fund in London, has developed the online resource that I mentioned earlier. And I'm just going to play you a brief clip, which is kind of, if you like, the promotional video for the King's Fund Experience-based Co-design Toolkit. It draws on various patients, members of staff who have taken part in EBCD projects, talking about their experiences and reflecting on the process as a whole. And the film lasts about 2 minutes, and then I'll show you some examples of what's in the toolkit before going on to talk about 3 particular adaptations that we've made more recently.
I had an experience of surgery recently, and it was very different to my previous experiences, and a lot of the things that had changed and become more positive were things that had been discussed in the group I was in. So I thought that was fantastic. You know, it's like this has really worked. It's made a difference. At times, the ideas that they came up with, their solutions and their thoughts about how things could be resolved were so straightforward. We make things very complicated sometimes, and the things that we thought needed to change often weren't the key priorities for patients, and that's what made a huge difference for me.
I think it was one of the most exciting and precious pieces of work I've been involved in.
The most amazing thing was to actually see patients, relatives and staff working together, and the catalyst and the energy that produced.
I think it was an encouraging experience for them. We made them feel, yes, do complain, do say that we got it wrong, because without you saying that, we'll never get it right.
Definitely the King's Fund Toolkit was vital in our understanding, and it provided useful information, how to run the meetings, what the methodology was, what worked, what didn't work, and so that was key. So definitely I point people to the King's Fund website.
So just to echo Mel's final point there, I think the starting point for anyone who is interested in implementing this approach or adapting it in some way is the King's Fund Toolkit. And I was just going to show you a couple of screenshots just so you get a sense of what's available. As I say, this is a free-to-access online toolkit. You had the web address on the previous slide. So it's broken into 16 sections, as you can see here, beginning with is experience-based co-design for you, what is experience-based co-design, and then taking the reader through each of the various stages. There's embedded film clips with those who have led the projects and those who have taken part in the projects talking about their experiences, and there are various resources, suggested agendas for the meetings, how you run the various feedback events, etc. in the toolkit. Here's another screenshot around how to go about interviewing and filming the patients. So we monitored quite what happened to the toolkit in terms of level of interest from its launch in August 2011. And as you can see, we monitored it for about a year, and after obviously the initial peak when it was first launched, it settled down to about sort of 2,000 views of the toolkit each month, with smaller numbers of downloads of the various videos. So it seemed that there was a certain amount of level of interest in this approach, this type of approach out there. And then more recently, this summer, we conducted an international online survey of EBCD projects. And I just wanted to share some of the findings from that with you. So just to give you a sense of where these projects have taken place, and this is obviously only a snapshot. This survey has the limitations of all surveys. I'm sure we've picked up lots of positive bias here. Only people who've had positive experiences with the approach have probably participated in the survey, and I'm aware of several major EBCD projects in the States and in the UK that didn't take part in the project. So we've only got a snapshot here, but just give you a sense of where these projects have been taking place and the nature of them. So there was the work in Australia around emergency departments, I've already spoken about. Lots of work in New Zealand where one of the health districts has adapted and produced their own form of co-design toolkit. Really large-scale project in Canada based in Ontario addressing the really important problem of transitions in healthcare between organizations and sectors. The CBO in the Netherlands has led and facilitated a number of EBCD projects, 5 projects in Sweden, and obviously several projects in the UK as well. And we asked it was quite a detailed online questionnaire. I'm just going to give you a couple of the questions today. We're hoping to get the final results and the final report from the survey out in the next few weeks. So if anyone's interested in seeing it, please do drop me a line. I'll give you my details at the end. We will be sending the report to everyone who participated in the survey. So we asked, one of the questions we asked was, thinking about your EBCD projects, what were the strengths of the approach? And as you can see, almost 90% saying that it really engaged patients and carers. Slightly less, almost 80% talking about it really engaging staff. We also asked what were the weaknesses of the EBCD approach. And I'll come back to this towards the end of this webinar, but clearly it's taking too long to go through the original way in which we developed and implemented the pilot, and significant numbers also finding it quite complicated, and I suspect that's the reason for similar results in terms of staff not engaging with the project. So it seems as if we had to make some adaptations in response to what practitioners and those who have been leading these projects were saying to us in the survey. Just a couple of other points from the survey findings. We asked people about what training and support they'd had to implement EBCD, and about half said they had not received any formal training at all. They'd either used the King's Fund toolkit to guide them, or the NHS Institute for Innovation prior to its closure last year had run a series of one-day workshops, and many of the people who replied to the survey had been on one of those one-day workshops. Non-participant observation, I've mentioned this already, it did seem that it was being relatively underused as an approach, and I do think it is, as I've mentioned, a really powerful part of the intervention and indeed of quality improvement work more generally. So it was slightly concerning to see that non-participant observation was being relatively underused. About half of the projects had included filming patients, and again this was slightly concerning because I think, from my experience of directly participating in these projects, the visualization of the patient experience through the film, however that's done, is a really important part of the process. And I'll show you some quotes later about how the films have helped maintain the direct connection between patients and staff, and I think that's an important component. So again, slightly concerning that not a significant proportion of the projects weren't actually using film in some form. I think the survey findings also raised the question of the scale of change. From the breast and lung cancer project that I briefly presented, you could see that we were trying to get a handle on what were the nature of the quality improvements that were being made as a result of the project, and the majority of them are in that sort of quick fix category. But I think increasingly we're coming to realize that this sweating the small stuff is really, really important. What may seem as relatively trivial and unimportant to staff, to those leading quality work in healthcare organizations, is actually very fundamental to patient experience. Plus, I think the impact of these types of approaches isn't just about the specific quality improvement improvements that are made. It's also about those much harder to measure impacts around staff engagement, around changes in behavior, and potentially changes in culture in these departments that take part in these type of projects. Which brings me on to one of the major points I'd like to make, really, which is around the crucial role of the co-design phase in experience-based co-design. the sense from the survey findings was that those leading these projects had really welcomed the work around capturing, understanding patient experience, whether it be through film or other methods. But it was much more challenging to implement the co-design phases. And it's certainly challenging to begin to get a sense of the impact and outcomes from co-design work. And I think those of us who are passionate about patient-centered quality improvement interventions have now got to begin to get much tougher with ourselves around how we begin to show benefit and evaluate the impact of those types of approaches. And on that point of evaluation, less than half of the projects in the survey were aware of the cost of their projects, so it remains a big gap, I think, that there is no formal cost-benefit or cost-effectiveness studies of experience-based co-design, and we need to address that. But equally, I'd say that about quite a few patient-centered quality improvement interventions, and indeed much of the PPI, patient public involvement work, that goes on in healthcare organizations. Again, I think we need to begin to become much tougher with ourselves around formal evaluations of these types of interventions, difficult and complex though that may be. So as I said, I think particularly around the co-design phase, that's where the real impact and the real magic, if you like, of these approaches lies. And some concern, I think, from the survey responses and from anecdotal discussions I've had around how challenging implementing co-design remains for practitioners and those leading quality improvement work. Just in the final few minutes, I just wanted to give three recent examples of how the approach has been adapted. Firstly, used as an integral part of the development and evaluation of a complex intervention. I'm going to draw on a project that I was involved in looking at enhancing the role of carers in the outpatient chemotherapy setting in London. Then on how EBC has been adapted to mental health care settings. I think there has been a lot of interest in this type of approach in the mental health care sector. I noted on the registration form for the webinar that there are several people expressing an interest in implementing this type of approach in those settings. And I'm going to draw on a recent project from Oxley's NHS Foundation Trust on an acute mental health ward. And then finally talk about the faster and cheaper version of experience-based co-design in response to those practitioner concerns that it was too long and too complicated, the way in which we designed the initial pilot intervention. So we have, with funding from the National Institute for Health Research here in England, recently tested and evaluated an accelerated form of experience-based co-design in intensive care units and lung cancer services, and I'll just briefly tell you a bit about that. So the first one, carers of patients receiving outpatient chemotherapy. So this was a project where we used experience-based co-design in the context of the Medical Research Council's complex interventions framework. So we used experience-based co-design in the way that I've described to develop a leaflet for carers of patients receiving outpatient chemotherapy, and also a DVD of carers talking about their experiences. But importantly, we didn't just stop there in terms of producing those communications materials. We also used co-design to develop the process by which those materials would be used by carers. And the model that we tested and developed was around a small group consultation led by a clinical nurse specialist with 3 or 4 carers to watch the DVD together and to discuss it in a group. I think one of the important points that I mentioned about this particular case study, this particular example, was that it was a integral part of a feasibility trial within the context of the MRC Complex Interventions Framework. So we co-designed this the intervention, which was the leaflet, the DVD, and the process for delivering that, and then we used the intervention in a feasibility trial. And just to show you, these are obviously very small numbers. It's just a feasibility trial. We're moving to a full-scale trial later this year. But even though they're small numbers, we did seem to pick up some interesting findings regarding the impact of the intervention and the process of delivering it in terms of the intervention and control group at baseline and follow-up. And on a range of measures around practical advice about managing cancer symptoms, the unmet information needs of the carers, and their confidence in supporting patients if their health got worse. The second toolkit I was briefly going to mention was around adapting the approach to the mental health care setting. This is work done at Oxley's NHS Foundation Trust on a BETS ward and acute care ward. It's had quite a lot of interest in the last few weeks following a publication in the Guardian newspaper in January. This is work led by Neil Springham and Amy Woods. So Neil and Amy took the EBCD toolkit and they looked at the fundamentals of that process, looked at what were the potential stress points in applying it in an acute mental health care setting, and then developed a series of what they called resolution factors to adapt the approach to the particular mental health care setting, as you can see here. These are some of the staff questions that emerged from the co-design process to their service users. What does a well-conducted admission look like? How can staff apply blanket rules while attempting to build an alliance with new patients? The basic needs of a ward patient? How can conflict be dealt with well, etc. And as a result of that project, several quality improvements actions have been put in place. You can see them listed here. And if anyone would like specific, more details about the specific case study, because I know there were people interested in the application in the mental health setting, just let me know and I can put you in touch with Neil and send you some more materials. But also, they did collect some outcomes data in terms of in terms of the number of complaints on the particular acute ward where they implemented the approach. The intervention was in July 2012, and you can see that up to that point, there was typically at least one complaint each month. Since the implementation of experience-based co-design, this acute ward has not had any complaints. But also some of the more qualitative feedback from one of the service users who took part in the project. On a personal level, this has been a memorable journey. When I was on the ward, I would never have imagined being part of this work. If I could have seen myself in the future, I would never have believed it. I thought my life was over. Now I'm alongside the ward manager as a colleague, not a patient. To turn a terrible experience into something productive has been fundamental to my recovery, and more importantly challenges stigma, which needs to be challenged hard. And as I say, there has been lots of interest in the mental health sector, and I'm really pleased to see that there's going to be a large-scale cluster randomized control trial led by Dr. Victoria Palmer at the University of Melbourne, where they'll be investigating the impact of consumer and staff co-design of mental health services at a range of community health centres across Victoria. And that will be looking to improve the recovery outcomes of people affected by mental illness. And that study has been launched in Melbourne in March. And the final case study I've just briefly mentioned, because I think it is an important development in the approach, is the accelerated version of experience-based co-design. So this, we set out to retain all 6 stages, components of experience-based co-design, but to shorten the time frame, directly in response to the types of concerns you saw in the survey, that people welcomed the approach, but it was taking too long. So rather than collect local patient narratives, going out, filming 16 to 18 patient carers in a specific locality and producing a new edited 30-minute film, could we use already available national trigger films relating to the patient condition instead of those? Again, we employed local facilitators, so the same model that we tested in the breast and lung cancer services, where we did knowledge and skills transfer to local facilitators within organizations. And we attempted to halve the overall cycle from 12 to 6 months. So EBCD projects, if you like, implemented the traditional way, took up to 12 months. What we were trying to do was to halve that in this accelerated version. And we tested it in 2 intensive care units and 2 lung cancer services. And a separate evaluation team observed how this affected the change process and outcomes. So essentially, it's exactly the same process, but instead of gathering the experiences empirically in the locality, we drew on a nationally available archive of films that's hosted by Health Talk Online. That has a collection of patient narratives for a range of whole conditions, and we tested whether we could use those as trigger films for the co-design process. So we're saving lots of time at the start of the process in terms of collecting the patient and carer narratives. And I was slightly skeptical that this would work, because I had seen how powerful it had been for the patients and staff to tell their own stories and to see the films together as a group. So I wasn't sure if this would quite engage the patients and staff to the same extent. But other than that change at the start of the process, it was exactly the same. It was using the emotional mapping techniques, touch points, bringing the staff together, bringing the patients and staff together to then go through the co-design groups to work on the specific improvement priorities. And what we found across these 4 pathways, 48 co-design activities. So examples you see here from the intensive care unit, and some examples from the lung cancer unit. And all of that will be published very shortly. We're just waiting for the permission from the National Institute of Health Research to publish the final report. But what we found was that we could indeed halve the time by using these nationally available films. It results in about a 40% cost saving of implementing experience-based co-design. And importantly, it seemed that the nature and scale of the quality improvements that were made in the accelerated projects were the same as we had found in the historical, if you like, traditional way of implementing experience-based co-design. I mean, I do think on the cost side, there is a loss to the individual participants in that they don't get to tell their own story and to see their own films and to share their direct experiences in quite the same way that they did when we piloted the approach and in the traditional way of doing experience-based co-design. But in terms of driving local quality improvements, it seems that these nationally available trigger films are sufficiently engaging to start the co-design process. And it is the co-design process that is really the important part of the approach. There's a few more qualitative quotes to end with. This is almost the penultimate slide. So the first quote is from actually one of the Australian ED projects, and I think it's an important one. For me, this is about, oh God, there are patients, aren't they? When people watch the film, they might think, I remember that lady. They know there are patients. They can't get away from the fact, but it actually makes it more real for them. Whatever way they're captured, it's about capturing it so that people recognize these are patients I have cared for, nursed, met, who are saying this. And I think that's what is so different from other improvement work in terms of things like discovery interviews and focus groups. It's that direct connection between them. So as I mentioned earlier, it's this approach and approaches like it, one of the core aspects is that it does retain the direct connection between staff and patients. And I think the film and the visualization of the experience is an important part of that. And the second quote from a staff member in one of the accelerated projects, it was one of the most meaningful things I've ever done in my entire career, I think. That sounds really trite, but I really do mean it. It was wonderful. I'm glad I had the opportunity, even though I felt like an emotional rag doll by the end of it. It was a great experience. If we could do more of it, I think it would really help. It's the level of engagement that we should do, but we just don't invest the time and the energy and the money. We wait for complaints. And I think that quote does point back to the issue I was raising around we must get much better at formally evaluating the cost effectiveness and cost benefit of these types of approaches. So just to finish, some future directions. We've launched a revised version of the toolkit. The original toolkit was launched in August 2011, and the first major revision we completed in November 2013, and that's now available on the King's Fund toolkit with new case studies and etc. There's also a LinkedIn group which I'll give you the address to if you're interested in joining. As I say, we piloted the accelerated version of EBCD. The EBCD is now being included as an introduction to the approach in the NHS Leadership Academy online program, which is going to be delivered in the next 3 years in England. Importantly, NHS England is now funding a new Train the Trainers course, which will be a very in-depth, hands-on, practical course in EBCD, hosted and facilitated by the Point of Care Foundation. And I think perhaps most importantly, there's much more rigorous and robust studies of the effectiveness of this approach now underway. Several PhD students, certainly in England, studying the approach. There's the feasibility trials of co-designed interventions. I gave you the example of the carers of outpatient chemotherapies patients, onto large-scale cluster randomized control trials, such as that taking place in Victoria and Australia. So I'm just going to end there. I'll leave this slide up with some further information. There's the web address for the online EBCD toolkit. the web address for the LinkedIn group. Anyone is free to join. There's about 100 members at the moment sharing their experiences and reflections on using this approach. My email and Twitter details. And if you're specifically interested in the Point of Care Foundation EBCD training course, the first cohort will begin in July. And there's an email address where you can register your interest. So thank you very much for listening, and I'd be very happy to take any comments or questions.
Hi, Glenn. Thank you so much for that presentation. That was really excellent. Can you hear me?
I can. Yes, that's fine.
Super, super. Sorry. So there was a huge amount of information in that, and it really very simply and very effectively demonstrated really understanding the patient experience and how that can be properly understood for quality improvement purposes. So really, really excellent presentation. Thank you so much, Glenn. I just have a few questions in. The first one is, how were you able to do the non-participant observation without any Hawthorne effect?
Well, I mean, I think this is part of the I skipped over the setting up phase because I just didn't have time. Please do have a look at the toolkit around advice on how to carry out the observation. But I think this relates to how you engage with the staff and patients at the beginning of the project. I think it also relates to the skills of the researchers and the research training in the approaches to non-participant observation. In part, I think you have to be pragmatic about doing this type of work. Yeah, that's probably all I'd say on that.
Okay, just hold on one moment. And could you please elaborate more on some of the filming of the patients? Were these patients simulated, or how was this done?
Was that simulated, sorry?
Yeah, were the interviews simulated, or how did you go about getting participants to get involved?
No, so in the pilot and the traditional way of using experience-based co-design, where you don't have an existing trigger film available from a national archive, for example, Health Talk Online, these are interviews with real patients and carers, typically interviewed in their own home. Typically interviewed in pairs, actually, and so these are direct interviews with patients and carers who have recently been through the service where the approach is being implemented. There's always the issue of how do you recruit these patients and how representative are they of the patient group more generally. My response to that is that the key role of the films is to trigger the co-design process. So representativeness is not such a key factor when it comes to the filmed patient interviews. It's more about getting good informants who are happy and prepared to tell their story in a way that will help initiate the co-design phase, which is where the quality improvement work really kicks in.
Great, thank you very much. And one final question before we close up for today is, hold on a moment. What is your experience of its use in the primary care setting, so in general practice?
Yeah, it's that's a question that often comes up. I'm not aware of any specific projects using experience-based co-design in the primary care setting. There are projects such as the work in Canada, I think, the PATH project, where they're looking at transitions between different sectors and organizations, where I suspect that they're touching on those types of issues, but I haven't directly been involved in any implementations in primary care work, and the survey didn't throw up many specific examples either.
Okay, super. I think we'll leave it there for today. There are some more questions and comments coming in, but I will get to everybody individually and I'll send them on to you, Glenn, if that's all right.
Yes, of course, that'd be great. Thank you.
Super, super. So thank you again so much for your presentation today. It really was excellent, and I look forward to following up with all of our participants afterwards. Super. Thank you, Glenn.
Great. Thank you. Thank you. Bye.
Bye.